Welcome all. Welcome to this AimExcellence question answer discussion. In this particular question, you have responded tremendously. Doctors all around India and across globe actually responded for this particular question. As because this question have been asked before also in NEET PG examination and also in USMLE examination. So you found the similarity and you have actually responded generously. So the four options that have been given out here, one is diabetes, B is amyloidosis, C is membranoproliferative glomerulonephritis, D is all. So we will explore and we'll see where Kimmelston-Wilson lesion is seen. Before getting to the final answer, because you have responded so generously, AimExcellence, it is our responsibility from the side of AimExcellence to give you the pictorials, the changes that happens in diabetes, amyloidosis, and also other glomerulonephritis. So we'll give that, and then after we'll come back and we'll answer this particular question. As because time is very premium in front of you all, so we'll keep it very slick presentation. We're not going to explore the presentation. We will tell the additional data regarding each and every picture that I'm going to show you in our F2F presentation. But for this particular presentation, it is going to be concise one. Hope you like this particular presentation. So the first disease that we are going to talk about is the first option, that is diabetes. Diabetes mellitus. And this is the first change. The first change is the mild diffuse expansion of the mesangium. In diabetes, many part of nephron is affected. It is glomeruli, Bowman's membrane, tubulointerstitial segment, and also efferent and afferent arterioles. Efferent and afferent arterioles. So there will be fibrosis in the tubulointerstitial region. There will be fibrosis here. Fibrosis. There will be efferent and afferent arteriolar hyalinosis, and also involvement of the glomeruli and basement membrane. So we already have talked about the first change. So the first change is the mild diffuse expansion of the mesangium. On the right hand side, what you are seeing, it is the most common change that is seen in cases of diabetes mellitus. And this is known as diffuse glomerulosclerosis. And these all are past staining. And this past staining is showing the increase in the mesangial matrix. Mesangial matrix is increasing due to non-enzymatic glycosylation. Non-enzymatic glycosylation. So these are important points for your upcoming MCQ examination. Now the next picture that you are seeing, it is the most specific and virtually pathognomic, and this is KW lesion. KW lesion. It is virtually pathognomic but not pathognomic. So it is seen in other conditions too, and we are going to explore that too in our presentation. Not pathognomic. And this is nodular glomerulosclerosis. This is nodular glomerulosclerosis. This picture is showing the silver staining. We will tell you what is the extra staining apart from fast staining is needed. This is the silver staining, and where it is showing the glomerular lobulopathy. So it is also a case of diabetic glomerulonephritis. Associated with that, few other things are important. They are frequently asked in the MCQ examination. One of them is the fibrin cap. This is fibrin cap. Fibrin caps. And we already have talked about afferent and efferent arteriolar hyalinosis. This is afferent and efferent arteriolar hyalinosis. So this pictorial question can come with a different trunk of the question, can be set in a different way, can give with a clinical scenario also, but this sort of question can come, and that is why we are putting all those pictures in front of you, as because we are rarely going to upload our F2F presentations, but once we are doing it, there is no point in holding it back, and we are also here not telling you all in details, all the extra points, but little snippets of it, so you can understand what you can get in F2F. Along with this, we are also going to show you the picture of immunofluorescence finding. So this is linear IgG in the glomerular basement membrane. And also we have to remember the C3 staining in the glomerular capillary, if it is not present, which is an important negative finding for glomerular nephropathy. So if it is not there, it is a negative finding for glomerular nephropathy. Diabetic glomerular nephropathy. It is going to be important negative finding for the diabetic glomerular nephropathy. And on the right hand side, we are showing you electron microscopic finding, where you are seeing diffuse thickening of GBM, diffuse thickening of glomerular basement membrane without immune type deposit. So diffuse thickening of glomerular basement membrane without immune type deposits that you are finding out here. Another condition where you can find Kimmelstel-Windsor lesion, KW lesion, which is amyloidosis, and it is renal amyloidosis most of the cases. It is actually associated with systemic amyloidosis, and here you are seeing the fast staining which is showing the glomerulus and the capillaries involvement. And it is also, there is a special staining. This is Thioflavin T. It is Thioflavin T, which is give yellow green staining. Thioflavin T, or S, but this is Thioflavin T staining, and which is give yellow green staining. This can be a one-liner for FMG examination and also for the NEET PG examination. Continuing with the amyloidosis, this is another special stain, that is Congo Red staining, which is mostly known. Many times in many examinations the question also came previously, and the question can come upcoming examination with the pictorial. So that is why we have incorporated and added to the lecture video. And this is the reddish pinkish appearance, and under polarized light it gives apple green birefringence. This is the appearance also. Right now pictorial questions are very common, so this can be your new future question also. The way we are actually presenting this F2F, limit t tends to 0, F2F, you can understand a little bit of maths, remember a little calculus. So this is apple green birefringence, and even in the upcoming 2-3 years, I think this video, many questions will come from this video. So we are also showing you another condition which will mimic is diabetic nephropathy. So that is LCDD, light chain deposition disease, and under past staining it is going to show the similar nodular glomerulosclerosis or Kimmelston-Wilson lesion. So that is going to be similar. It is very difficult to distinguish in between them. In that case, we will going to go for immunofluorescence staining, and it is the kappa chain. It is the kappa chain that is showing out here in the glomeruli and tuberointerstitial also. So this is light chain deposition disease. Only by doing immunofluorescence staining we can distinguish in between them. There is a rare known condition, rarely known, that is rarely studied, fibronectin glomerulopathy. The past staining features are going to be indistinguishable from diabetic glomerulonephropathy. It is fibronectin glomerulonephropathy. How to distinguish in between them? One is silver staining. Silver staining. We have shown the silver staining positive already once. So silver staining is going to be negative here. And there is a special stain. Immunoperoxidase staining for anti-fibronectin antibody. That is going to give you the rise to this sort of visual impression. So that is where you are going to distinguish in between them. Like a central institute examination, if they mention or if they give this sort of picture, so and the two options are there: fibronectin globulopathy or diabetes globulopathy, diabetic glomerulonephritis or fibronectin glomerulonephritis. Both are there. So if this particular presentation is there, you is obviously going to choose the fibronectin glomerulonephritis. Another condition which can give rise to past staining, similar to diabetic glomerulopathy with Kimmelston-Wilson lesion, but you can distinguish them under electron microscope. Under electron microscope, where you will be able to show them the large microtubular structure out here. And another condition also, idiopathic nodular glomerulosclerosis. Just by past staining, both again it is going to give rise to Kimmelston-Wilson lesion. But how to distinguish them? It is no specific staining, it is a clinical feature. Their sugar level are going to be normal. So it is idiopathic nodular glomerulosclerosis. So you can do the fasting sugar or postprandial sugar, which is going to come up normal. So that is the way we will be able to distinguish in between idiopathic nodular glomerulosclerosis and diabetic glomerulonephritis. Idiopathic nodular glomerulosclerosis and diabetic glomerulonephritis. So this is where the clinical features are also very important. Clinical findings are going to be, biochemical findings are going to be important to distinguish in between them two. So by now we have understood there are many conditions where we can show you the Kimmelston-Wilson lesion. We understood that by now many conditions where there is a Kimmelston-Wilson lesion is being there. So, and we also understood diabetes. In diabetes, the glomerulus, the basement membrane, the tubulointerstitial region, all are arterial hyalinosis, efferent and afferent arterioles, all are involved. So in the case of amyloidosis 2 and membranoproliferative glomerulonephritis, particularly type 1, that also shows the KW lesion. So the answer for this particular question is all. Few salient important points that we should remember. The first sign that we can see, that is microalbuminuria. This has been asked before also. Microalbuminuria. It is 30 to 300 milligram of albumin, 24-hour collection of urine. Can you say whether in this case dipstick test is positive? No. The dipstick test is going to be negative in cases of microalbuminuria. Dipstick is going to be negative. These are not part of the KW discussion, but these are the extra salient point, because you are spending so much time in seeing this video, you should have extra information which is going to aid you for your upcoming examination. And diabetes, you know, so much important. 1 or 2 questions surely should come from the diabetes. I don't know if it's going to be pharma angle, it's going to be patho or clinical findings, but the question surely is going to come. And there is another parameters, 30 to 300 microgram of albumin per milligram of creatinine, and it is considered better data to confirm microalbuminuria. we already have known that diabetes is one of the major causes, or one of the chief causes, that ends patient with the dialysis or end-stage renal disease. Dialysis or end-stage renal disease. So microalbuminuria, by on-spot collection of urine by doing the 30 to 300 microgram of albumin per creatinine, is the major criteria to diagnose the condition. Microgram per milligram of creatinine. This is the major criteria, and once you are being able to diagnose a microalbuminuria, you will be able to control the situation better. As per drug, we have to give ACE inhibitor or ARB, angiotensin receptor blocker. So regarding that presentation, that total integrated presentation, it will take much time. It will be almost 2 to 3 hours presentation. So you can understand it is going to be very difficult for you to see that continuously for 2 to 3 hours. But we always try to incorporate extra information, because once you are spending your 20 minutes time out here, or 20 minutes plus time, you should get the extra information that helps you to mark the answer, even 1 or 2 out of the 300 questions that is going to come up. So if this presentation actually helps you to do so, we will feel our effort is actually got what is due for, what is the purpose is going to be served. So to give you this F2F presentation, and the best diagnosis for microalbuminuria is radioimmunoassay, sensitive radioimmunoassay. Hope you will find this particular information informative enough. All the details that we have given you regarding the diabetes, amyloidosis, fibrodectin, glomerulopathy, and idiopathic nodular glomerulosclerosis, all the findings are very membranoproliferative glomerulonephritis. All these particular topic are very important, and you have to be aware of all this information, because you never know from which angle. I am not being aware from which angle the question can come, but Kimmelston-Wilson-Lesion most have marked diabetes, so that is going to be a wrong answer, and the answer is going to be D, all. And why it is so, we have also given you the pictorial presentation of all the important aspects. In the real F2F presentation, we give all the images, and also we tell a little bit in detail. But in this particular presentation, because you are going to show it, see it for almost 25 to 30 minutes, so we are incorporating a little bit of each and every information that is actually going to be helpful to you for marking your MCQs. And if this particular presentation actually helps you to mark one question even correct, then the purpose is solved. That is why we have uploaded this presentation, because you have given a tremendous response to this particular question. Thank you for liking us. Thank you for responding to our questions. If you support us, we'll never forget you. We'll be with you. Whatever little support that we can do from our side, we'll do that for sure. And if you like this presentation, if you feel it's worthy enough, please follow our YouTube channel and also our Facebook pages. Thank you.